So we have the next hour to kind of go over ER nursing. And the way that I present this is to talk about what I would consider like a day in the life and answer some questions. I want to have some opportunity at the end to kind of just open up the floor and talk to you all about and answer questions about this. So I'll go ahead and get started. Let me share my screen. All right. So as you all know, my name is Patrick Luna. We'll be discussing a day in the life of an ER nurse today. So I know many of you are probably interested in this field, and it is a rewarding field. It is unlike any other area of nursing. So this is going to be eye-opening for a lot of you because I know that you all don't get a lot of training on this in your current curriculum. So hopefully I can shed some light on some things and maybe some of you decide this is what you want to do. So for a lot of you, this is kind of what you think you're going to be doing. You're going to be saving lives, clutching death, life from the clutches of death, and with your metal syringe in hand and bombs exploding around you. And in this picture here, you took off your gas mask and there's all this mustard gas around, and you did it all to save your fallen comrade. That's pretty noble, but in this picture, who's going to save you? Now there are two victims, and the one wearing the gas mask also has a gunshot wound. So probably the first lesson that we learned as ER nurses is that we need to be smart. And so this whole image is a common misconception. We get into some really hairy situations in the ER, and we do train for those events, but I would argue that this image here and the self-perception of ER nurses, I think that needs to evolve, and I really think it needs to change. I would very much prefer that the image of an ER nurse be this. So an elderly male patient has fallen, he's injured and scared. We've stabilized him in the ER, and everyone has decompressed after the initial chaos of what would be kind of an involved trauma after assessing his injuries. So a nurse not assigned to this primary patient comes up, walks over to the patient, holds his hand and says, "I know you're scared and I know you're in pain. We are doing everything we can to help you. Your injuries are not life-threatening, and we will help you with your pain. Is there anyone that we can contact so they can be here with you?" In the ER, we save lives. That part is true. People arrive in varying stages of sickness and injury, and they all believe they are genuinely experiencing an emergency. Due to the stress that this causes to the population, to the people that are seeking care, there are countless opportunities to inject the caring behaviors that we've taught you in foundational nursing, that you're learning in nursing school. It really took me a long time to realize that this is just an extension of nursing care and not something that is separate from other areas of nursing. And I hope you take that with you. So my background, some of you know about this. I was a firefighter and a paramedic with Houston Fire Department. I did that for about 12 years, started when I was a very, very young man. I was a flight paramedic for a while with Herman Life Flight, which is their claim to fame is that they are the first civilian flight service in the country. And it was started by a very influential and famous doctor. I went into emergency nursing right out of nursing school. I have level 1 trauma experience. I did that at Ben Taub General in Houston, Texas. 80% of our trauma activations were of penetrating origin. We were kind of the shoot 'em up, stabbing hospital, that if you had a penetrating injury, we were just really good at that. I was a trauma coordinator for a while. I am still a TNCC instructor, which is a trauma nurse core curriculum. And I was involved in joint training with advanced trauma life support, which is how physicians are trained. So I became a trainer in that to train on the nurses side as well. So I'm also certified in emergency nursing. I've been certified for quite a while, and we'll talk a little bit more about certifications later. And I went into trauma surgical ICU. I still have a bedside practice at UC Health Hospital. So I know that a lot of you, or some of you who come up to me and talk about ER nursing, have EMS experience. And I was a paramedic for, like I said, for many years. So it did help. It did help with that transition, but it's definitely not everything. EMS is very skills oriented. It's protocol driven. Um, Clinical decision making is based on like a formula, which is something that as a nurse you really need to break from, because we teach you all critical thinking rather than adhering to some formula for how to treat patients. Probably the most eye-opening experience, and I know that a lot of you in EMS don't get to experience this, but true QI. That's a picture of Dr. Red Duke. He is the famous physician who started civilian flight services. He would actually sit me down and make me explain what I did on scene during some of these emergencies when I was on the helicopter. I had never experienced that before. I learned more from those interactions than anything that I'd done in healthcare before that, and I'd already been a paramedic for a while. And so there's some other differences with EMS. It's geared toward one patient. So if you start treating multiple people, I just felt like a fish out of water. And there are numerous attitudes and professional norms that are different in that world than they are in nursing. So that's part of the acclimation. That's part of recognizing a new role. I mean, I was a paramedic who was trained to, intubate and start chest tubes and do central lines, and I did all those. Those were skills-based things, but I didn't know how to change a bed with a patient in it. So there were a lot of different things that I had to learn and start over with, despite that I had all these because EMS is very, very, very skills oriented. So I did learn to appreciate like the nursing side of things, and kind of meld those experiences that I had. So that's a picture of me in nursing school. That's just a old picture. I didn't have the same kind of experience that you all have here at the college. I went to an associate's degree program that was literally in a storefront next to a grocery store. But I learned a lot there, and there was some great people that I learned from as well. The thing that struck me the most was evidence-based practice. No one had ever talked to me about that in all the years I'd been in healthcare before that. And I kind of had this attitude, starting over, doing something. My father, who was a drill sergeant in the Army, literally told me, when you go to nursing school, you don't know nothing. And he didn't say it that way. He said something else. But he said, you don't know anything. You start just like everybody else, and you learn and build because you're learning something new. And I never forgot that. And it kind of like became the basis for me just wanting to learn more, is because I realized that I don't know everything. And despite, the fact that I had done all this other stuff in healthcare, I was starting over with a new role. And many of you know now, I mean, I've done critical care and trauma and all of these like kind of advanced kind of things. And I teach foundational nursing theory now. I teach foundational nursing classes, and I love it because that was where I had to acclimate to. And that's part of becoming a lifelong learner. And I love doing that for you all, and helping to redefine this role for you all, because I had to do it myself. So I went on, got my BSN online at University of Texas, and then I got a master's in education. And all of this is just outlining the fact that, being a lifelong learner in any specialty is just a gift. It's something that you can there's just so much out there to learn. So as a new graduate nurse, and I know many of you possibly will make this transition. So a new graduate nurse in the ER is a very, very tumultuous and redefining experience. There is nothing in your current curriculum or anything that you've done in your program that prepares you for just the unique nature of what ER nursing is. So I went right out of nursing school as an EDN, and I went to the second busiest hospital, or ER, in a very large city. I spent 1 month with a preceptor, and him and I had a great relationship. I learned a lot from him and realized that there was a lot that I still had to learn. But he was my connection, and we're still friends to this day. And we talk about it all the time about, kind of the things that I didn't know that I had to really just like start from ground zero and learn my job. There's a huge learning curve. Pediatrics, because of the fact that in the ER, we treat everybody who walks in the door, regardless of age. There are some agencies that have like specific pediatric ERs, but for the most part, as an ER nurse, you have to learn to treat across the age spectrum. Pediatrics was a big learning curve for me. If you have the most common complaint, or when this work was really important, was for a baby who is less than 2 months old, comes into the ED and has a fever. They automatically get a sepsis workup. So 2 month old or less, this can be a tiny baby. They need blood work. They need blood cultures. You have to get a straight cath urine from them. They need a chest x-ray. And a lot of times I was doing that by myself with hopefully with the help of another nurse or with a tech, but a lot of times I was employing the parents to help me out with this as well. That takes a long time to really acclimate to and to get good at. In fact, I went to a specific pediatric ER due to that deficit. I wanted to learn more about pediatrics because it's a big portion of treating patients in the ER. So there are different professional norms in this environment. Everything that you learn in nursing school is very planned, and as far as like how you approach care with these plans of care, there are professional norms in nursing that and specifically in ER nursing about working in this professional environment is very fast paced. There's a very specific type of mentality that works there, and it can be there can be conflict. So, and that's true with any environment, but in the fast-paced nature of the ER, a lot of those conflicts become very vocal. And so it's definitely something that I had to really learn how to do. And, as a male nurse as well, most of my nursing colleagues were female. So learning how to go from a male-oriented, environment as a firefighter to this very female-dominated world of nursing. So there was a lot of professional norms that I was navigating at this time. And probably the biggest one is just feeling like I wasn't a drain on my colleagues as the new person. Just, I needed to ask for help. I wanted to ask for help, but I was kind of had this machismo thing going on too. It's like, I know how to handle myself, but I really needed to learn how to ask for help. And if y'all have been in my classes, I really stress that with you all, because looking back, I shouldn't have been as reluctant to ask for help. And that's actually being a safe nurse, is by asking for help. I moved to Ben Taub General. That was the big level 1 trauma center in town. I was really familiar with it from my time as in EMS, and I really wanted to become a part of their team. I knew how they worked. So while I was getting my BSN, I moved over to that ER. Okay, so we're going to describe a little bit about the ER environment in general. So one of the biggest differences about this area of the hospital than any other area is that it is really dynamic due to the fact that there is no patient filter. You are literally treating people as they walk in from outside. So there is no surgery where they get cleaned up and then they come to your unit. There is no ER where we kind of clean them up and then they go up to your med surg floor. But this is very much just dealing or treating the public. So that is just probably the core value of that environment, is we really don't know what's going to walk through the door. After many years doing that and even working in triage, I'm still surprised by the kind of issues that people come to the ER with. And it's, and we have to, no matter what, we have to treat them, and we have to learn how to best care for them. So it's a lot of problem solving. It's utilizing resources that we have or asking for resources that we don't. So it's definitely a collaborative environment, because I can have 4 patients. One can be a baby, one can be an older adult. A patient might be coming in for an assessment about an STD. There are multiple just kind of issues and things that we have to become familiar with. I mean, we do have a collaborative team and a multidisciplinary team that can assist us in this. The longer you work in this environment, you do start to really become aware of what the common complaints are. A big part of this environment is the fact that it is so reactive. We can't really plan for who's going to come into the ER. We don't know what our day is going to be like. So it's very reactive. We are listening to people and treating their complaints. We are reading diagnostics and then developing a plan of care as we go along. Some people are very, very comfortable doing that. Some people aren't. And so this is in a direct contrast to what you learn in school, which is very, very planned oriented. You show up, you read a chart, and then you start planning care. And you have a blood sugars at 9. You have you got to turn the patient at 10, and then you got to get an antibiotic at 11. That is not what the ER is like. In fact, when I had to learn how to do that, it was completely foreign to me. And so this is a very, very reactive environment. Anticipating orders is valued. The more you treat these common complaints, the better you get at anticipating how these patients are treated. So the most common complaint in the ER is abdominal pain. I mean, I became an abdominal pain wizard. I mean, I knew what, if you had pain in the lower right quadrant and you were throwing up, I mean, you might have appendicitis. If you, ate a spicy meal and all of a sudden you didn't feel well, and this has been going on for months and months, and maybe you have a gallbladder issue, and that's, right upper quadrant. Diverticulitis, left lower quadrant. Those are the kind of things that you kind of get to know after a while when you see how these things play out, and and how we treat specific things. So it's anticipating orders, working in collaboration with providers. I mean, you also know how people are not supposed to be treated. So if somebody puts in a funky order for something that is treated differently, we speak up about those things. So we become a very vocal part of the treatment of our patients. So stress inoculation. I don't want this term to be confused for you all. This is in line with what we do in like simulation. So working in these high stress, high stakes environments, you do get used to working in that environment. That picture there, I trained 2 of those nurses there. One of them trained me. And I can tell you that those 2 nurses that are treating that patient right there, they didn't look like that when I was training them. You have to learn how to exist in this environment, and part of that is knowing your role. So what exactly do? I start an IV. The physician's going to be at the head and checking out neuro status and talking to the patient. So knowing where you fit in these high stress environments is very, very important. The most important thing is knowing that you don't have to do everything. So even if that was my primary patient, I might be over in the corner just charting on that patient. So knowing what you're supposed to do is part of reacting to the stress of the environment. And the reason I don't want to confuse that is that the stress of it is still apparent in many, many ways. This is a very, high stress environment. Despite the fact that you fit in and you know what you're doing, there's still decompression that's needed, and getting used to the sometimes horrific things that you see is not part of that inoculation. It's not part of dealing with that stress. Those things should always be abnormal to you. We have to understand that we work in an abnormal environment. And the more we think of it as normal, the more we discount who our patients are and what their experiences are. And again, it took me a long time to figure that out. 24/7, all day, every day. If you work in a busy ER, it's never nighttime. It's always daytime. The lights are always as bright as you see there. You know, people don't really sleep. It's always day. So even if you're at night, it might be a little bit, you know, you might see some different issues or different problems, but the ER does not sleep. It is all day, every day. So that's just one thing to understand. I know that, you know, if you work nights on a med surg floor and even in the ICU, we turn down the lights, everybody, you know, that's better for patients, but in the ER, doesn't happen. It's daytime all the time. So there is limited interaction with the rest of the hospital. This has to do with the unique nature of the ER, the unique training that's required of its nursing staff and, you know, other healthcare providers. But it's also something that's very explicit. A lot of ER nurses don't want to be a part of the rest of the hospital. I mean, that's not a broad generalization. I can put it to you this way: if you start in an ER out of school, there is more of a chance that you will never leave. We kind of encourage people sometimes to go to med surg floors and get a foundation in nursing care before specializing. I would agree with that in some instances. Some people, if you think you're good at this and you want to do this, chances are you might not ever leave, because this is such a unique area of nursing that it actually, and because of the limited interaction with the rest of the hospital, not only do they not want to go up to the floor, they don't even want to know really what goes on up there. They have their own way of doing things and their own way of interacting with their patient, and they know their role. So there is limited interaction with the rest of the hospital, and some of them like it that way. That's just the way that world works. Okay, so just some realities about the ER environment as well. There are some varying shifts. I've worked 9 to 9, I've worked 10 to 10, and that's 10A, 10P. You can work 6 to 6. There are some really interesting shifts that occur in the ER. The reason behind that is that 10 a.m. to 10 p.m. are the busiest times in the ER. So we want people to be there, and the most amount of nursing staff to be there during that time. So you may have a really strange shift. I worked 3P to 3A. I got off at 3 o'clock in the morning. And so I've done all kinds of different nursing shifts. It's kind of, there are opportunities to do varying shifts. The environment's very skills heavy. So in the med surg world and in other areas of inpatient nursing, we're offloading a lot of those skills so that we can more effectively manage care. I think that's a good direction that nursing is going. That's going to take a long time to trickle down to the ER. We're very hands-on with our skills. We do a lot of specific assessment skills, you know, starting IVs, things like that, which is sometimes delegated to techs, but there are, you know, putting in NGs. We do a lot of it's very skills heavy in that environment. Focused assessment. So you may not do a full head to toe on somebody. If they came in complaining of abdominal pain, you may just start asking them about their abdominal pain. You're not going to start asking them about other things. So it's a very focused way of thinking about assessment. In that sense, your head to toe assessment skills will change. You may not do that too much. You may not do that ever. So it's, you know, in the same sense that you would in the inpatient environment. You know, I'm an ICU nurse. I do a head to toe 3 times a day on my patients, and I'm, you know, kind of got my system down, but I didn't get that from the ER. My ER assessment was very, very focused on what you told me was wrong with you. So trauma management is a completely different animal. So that's a testament to the collaborative and multidisciplinary environment in the ER. So this is very, very like, what is your role in this setting? So this is something that we train for, and a big part of this is really recognizing how that assessment occurs and where we are in the assessment of a trauma patient. So if you've been to complex care and I came to your class and talked about this, you know, we go over the primary assessment, the secondary assessment. Just remember that the definitive care for any trauma patient that's serious or critical is to get to the OR. So we're trying to get those patients to the operating room so that the surgeon can fix them. But trauma management is something that when you get to the ER, you will be trained on. And it's just so that you know how you fit into their trauma care system. Can be hazardous. I can't stress this enough. When I was a clinical scholar and I was taking students, senior practicum students to the ER, they all had a very lengthy conversation with me. And I didn't stop that conversation until I was sure that they understood what I was trying to say. And what I was telling all of them was that this is not like any other place in the hospital, and especially if they've never been exposed to that environment. Because of that dynamic nature and the fact that we're treating patients directly from the street that come into the ER, it can be dangerous. We really need to be cognizant of our own safety. It's very, very important. I've watched nurses get hurt. I've watched nurses get hurt unnecessarily by putting themselves in situations that they probably shouldn't have. You know, we learn patient-centered care, and we should always remember that, but patient-centered care does not mean that we disregard our own safety. And so that's something that I've always stressed to my nursing students, and especially to my nursing students who go to the ER. As students, you should never put yourself in a situation where you can be injured or hurt. There are people in the ER who that is their job. We use security very, very liberally in the ER. So that is what they are there for. And please don't put yourself in any situation where you can be injured. That's something that I always stress with students when I take them there. It's definitely not for everybody. Definitely. Some people go to the ER for like a school experience or an exposure, and they never want to go back. And I don't blame those people. It's not for everybody. It definitely isn't. And there are people who go and they think it's heaven on earth, and they can't wait to start there. But so this is not for everyone. It's there are many different areas of nursing. This is only one of them. So I told you I volunteered for full-time pediatric duty. Other things I've done in the ER, I helped start the nurse trauma committee at Ben Top. That was one of the highlights of my time there. We worked collaboratively with our trauma surgeons and their team to build a training program for the nursing staff in collaboration with the trauma residents and the ER residents, and we did a lot of cool stuff. That's it was kind of the first committee I was ever on as a nurse, and so I have fond memories of that. I also was a part of an EBP committee and worked with a PhD nurse in representing the ER to incorporate EBP into our care. I really enjoyed that as well. I became a trauma coordinator there, which is a really interesting position. I helped to contribute to the trauma registry. So all the patients that came in who were injured in some way, I helped to track them through the hospital. And it was one of the first like desk things I ever did. And but it really broadened my horizon of what trauma care is and how it kind of, goes through the continuum of care from, an ambulance ride to getting discharged from the hospital. It's pretty cool. Certified emergency nurse. The Board of Certification for Emergency Nurses, they certify ER nurses. One thing that I will tell you that is very unique about the BCEN, they do not have a requirement for how long you need to be a nurse before you can get certified. All of you in our program are very bright. It's literally studying for a test. So if you can set aside a month or two and study for this test, any one of you can be a certified emergency nurse or anything. There's other certifications that this group offers. So I didn't know that until like I became a nurse, and I literally was studying for that test while I was looking for a job. And it was just because nobody told me I couldn't. It's not recommended, but there's no requirement to how long you have to be a nurse, an emergency nurse, before you take that test. It's literally just like studying for a test you would here. So it's you just need the time, and probably pay for a program, kind of go through it, start answering some practice questions. You take a test, and all of a sudden you're certified. That's how those work. But that is unique to that governing body. A lot of the certifications in nursing require bedside experience. So I was a travel ER nurse. That's ridiculous, because the places that hire travel nurses usually can't hold on to regular staff. So I would walk into these places all over the country and just get to work. I had with limited training. So that is why, if you want to travel as an ER nurse, you have to know what you're doing first. So you have to have a background and know how to function in an ER before you can travel as an ER nurse. It's just one of the things that's required, because I worked in rural Idaho in a hospital where they never even taught me how to chart an IV. And I was just going to work, and there was a bad methamphetamine problem there, and they needed help pretty immediately. I went into critical care because I wanted to broaden my horizon. I really found that as a hole in my training, and I wanted to learn more about it. And I've enjoyed doing that. But I also enjoyed my time as an ER nurse, and there's many different ways and directions you can go with that type of training. Critical care is one of them, but I had to start all over. I literally had to learn something completely different. You all have learned how to hang secondaries, and I didn't know how to do that. That's not something that we really do in the ER too much. And so I remember my preceptor looking at me as I hung primaries for everything. And she finally realized that I should probably learn how to hang a secondary. She tells that story to this day. All right. So just a few little stories about my time in the ER. So that's a picture of the ambulance I used to ride on, and that's a picture of the ambulance bay entrance to Bentop General. So this was one of the first patients I ever treated who as a traumatic arrest. So he was a 19-year-old male. He arrived by ambulance with a reported gunshot wound to the right side of his chest. EMS reports they just lost pulses and started CPR in the ambulance bay. So if somebody loses their pulse in the field and they come as a traumatic arrest, that's a completely different categorization. We literally only do CPR and then wait to get word from a trauma surgeon, because literally that's the only thing that can possibly save their life. So they came in. I was the primary nurse in one of our shock rooms that received this patient. So he had a gunshot wound right in the upper right-hand portion of his chest, right underneath his clavicle. Couldn't find any other injuries. So I hooked him up to the monitor, start running a code. Done that many times. That's my wheelhouse. I can do that. The trauma surgeon came in and took off my defibrillator pads, and I was just looking at him like, why'd you do that? And he took a scalpel out of his pocket, had us stop CPR, and cut that patient open from underneath his clavicle all the way down his axilla. He reached inside of his chest with a pair of like what looked like garden shears, but he cut the ribs all along one side and then dove his hand underneath his rib cage. And this is all while I'm standing right next to him. So he's digging around. We're doing other work at that time, but I'm just watching him. Just a side note, when he cut the patient's chest open, a load of blood just fell all over my shoes. And I decided I was never going to another trauma without shoe covers on. So PPE, it's important. So he's digging around underneath this guy's chest, and I see his eyes light up, and he takes his trauma resident, who's a trauma surgeon in training, and he puts her hand in the chest and then guides her hand to where he's touching. And then he looks at her and he goes, it's pulmonary artery. So when he figures that out, he cuts the chest open a little bit wider. He pulls the patients, and on the right side of the chest, there are 3 lobes of the lung. He pulled the lungs out of the side of the patient's body and put the lower lobes on the top and the upper lobes on the bottom. And he did this right in the ER room. Then he stuffs them back, the lungs back in the chest. I didn't know this, but that's until later when I asked him, but that's a technique called the pulmonary hilar twist. Because that patient was shot through the right-sided, through the pulmonary artery, he was tamponading the blood that was leaking into that lung by twisting it off. So he was holding pressure on the patient's pulmonary artery. A lot of the docs that I worked with there were military. They, I mean, some of them still had sand on them from being in Iraq and Afghanistan, and they would wear their, you know, their fatigues into our ER. And so I learned a lot of innovative things, saw a lot of innovative things while I was there. That was only one instance of that. You know, of course, there's other ways of doing that now. You know, what we would do sometimes is clamp the aorta when we crack the chest open to kind of force shock, to force blood, to keep blood from going into the lower extremities and keep it to the core, like the heart and the brain and the lungs. They have other ways of doing that. There's a balloon now that they use that they can actually inflate in the aorta, so they don't have to cut chests open anymore. Which, believe me, there was a super high mortality. Well, people were usually already dead when we did that, but there wasn't a huge chance of recovery after that. But that was my first experience. I mean, we got to do, I did cardiac massage on that patient, where we basically just squeezed the left ventricle. He went into VFib after we tamponaded the blood, and we did some internal defibrillation with these tiny paddles that were on our monitor. So that was an eye-opening experience, and we did that many times after that. That was just the first time that I saw that. This is more indicative of what we do in the ED. So 41-year-old female arrives to the ED with a complaint of abdominal pain. Like I said, this is the most common complaint. Patient is Spanish speaking only. I worked at an ER that had the largest uninsured population in the entire country. It was a county hospital, and there was over 1 million uninsured people there, and a lot of them were Spanish speaking only. So I had to learn on the fly. It's something that you know, I could still get through a ER assessment in Spanish, but it was pretty. We used a lot of translators. In fact, we had live Spanish translators where we could just call them to our room and they would help us to assess patients. So we should always use a translator. Okay, so triage is very, very important in the ER as well, especially if there's different areas of the ER. We want to get the right patient to the right time, at the right time, to the right provider. It's a work in progress. Only nurses are trained to do triage, and that's something that you'll learn if you haven't been to complex care. It's something that's in that curriculum. So we do triage. You don't do triage right out of school. It's something you really have to know the operation of the ER before you start to triage patients, because we make that decision who waits and who goes back. So it's a very kind of high skill set for learning that type of thing. So this patient here waits in the waiting room and then is taken to a treatment area. The ER nurse will see the patient first. So the type of assessment they're going to be doing is a focused assessment. So a lot of this is talking. It is more talking than it is touching, because I want to know what happened. I want to know what led up to this, and I need to ask those probing questions. There is nothing that I taught you in health assessment that is like that. I mean, we're always searching, but this is very specific. It's, okay, what happened? What brought you here? What exactly is going on with you right now? And we're trying to kind of narrow down how we're going to treat this person. So interventions we can anticipate. She's going to get imaging. She's going to get blood. If she's been vomiting, or had any issues with fluid loss or not being able to eat, she's probably going to get some fluid. And we're going to start those things pretty quick, and we'll probably give her some pain medicine as well. If you do that a couple of thousand times, you get very, very anticipatory with how that works. And you'll do this more than you will do the cutting a patient's chest open. This is 90% of what we do in the ER. It is the reality of what that world is like. It's a lot of people who have abdominal pain or a headache or something like that. And if you're not prepared for that, you can get burned out fairly quickly, because if you think this is all, gunshots and stabbings, it is not. It is treating people with abdominal pain. It does give you a very realistic and real world viewpoint of healthcare, because those kind of skills, because you're doing so much talking, you can use that in real life. And in fact, you'll find yourself doing that when someone says, hey, you know what, I've been having this pain in my belly. And you've seen 1,000 people with abdominal pain. So you just go into your line of questioning, and all of a sudden you're that person. You're the person people go to when they have a problem. And so that's just part of that real world type. You can apply these skills to your life and to treating your kids and to helping your neighbors. So this is very, very, very applicable. And those are the skills we learn in the ER. So what type of education? So this is a critical component of patients' experience. They're treated and discharged many times. So if there are things that we navigate, so it's important that they understand what we tell them and how to care for themselves at home. And we do a lot of work with social work and case management and helping people to get into better places. I've sent battered women to shelters to get away from people. I've helped kids to along with social work to get away from some horrible situations that they've experienced in their life. Those things gave me a lot of satisfaction, but it also peels the veil off of what happens in a lot of our country. And so that's you do a lot of good work, but taking care of yourself is very important in this world. We need to make sure people understand, and we can work within this multidisciplinary environment to do a lot of good. Again, like I was talking about earlier, anybody who is violent is a high risk patient. They don't wait in the waiting room. The priority is our own safety. And this is not something I took from any official communication about nursing. There are millions and millions of documents and white papers and articles on patient-centered care. I would argue that our own safety is just as important, especially since I've seen people get hurt, especially since I come from a world where, not everybody makes it home. So I always will prioritize our own safety and how we take care of ourselves. And that includes, physical safety and looking out for each other. I learned in the fire department that there's a hierarchy to being a rescuer. And that is, I make sure I'm okay. I make sure my buddy's okay, and then we can go and treat a patient and make sure that we're treating them adequately and they're cared for as well. And I never forgot that, and that's not something I hear in the nursing world. And I honestly think that's a big reason why people get hurt and put themselves in situations that just aren't safe. We're not rescuers. We don't run into burning buildings. That's not us. We need to be there to use our skills as highly trained professionals to help people to get better. But if somebody's violent, even verbally abusive, that's not part of our MO. We can choose to not be involved in those situations, and I tell nurses that all the time. Security is always there in the ER. Go ahead and give them a call. I wouldn't be even as close as that nurse there. I've seen too many bad things happen. And so that's important for you if you're going to be in this world. Please, please, please take care of yourself and make sure that you're taking care of your coworkers as well. Then we can help people to feel better. All right. So things that you can do. Adaptability, that is probably the biggest skill I can tell you to cultivate as a nursing student. This is because of this dynamic environment, you can't control it. So you need to stay positive, and you need to roll with what occurs in your professional career. You can do things to make this happen, but adaptability is something that you should communicate to people that you can do. If you get a senior practicum assignment that is not something that you want, how did you handle that? How did you react to that? Did you make that a positive experience despite the fact it wasn't what you wanted? That's what is valued in the ER world. Make contacts. If you have contacts in that world, please exploit them. It's a very, very small world in the ER world. So if you know people that do it or know somebody that's involved in that, those relationships are invaluable and should be cultivated. You can seek a practicum assignment in the ED. There are EDs in every hospital, so it's not impossible. It's not out of the question that you won't get an ED experience. So just that's something that you can do. There are ACP and tech positions where you can help in an ER and learn that environment, make some connections, and possibly start your career in that world as well. So you can join ENA as a student. The Emergency Nurses Association accepts students. It is very, very cheap. You'll get a newsletter. You'll be able to put on your application that you are a member of this professional organization. When you go to interview, you tell them you want to get certified, and you're going to work as hard as you can to get those skills so that you can be certified. Increase your knowledge base. There's all types of information that you can get on ER nursing. You can obtain these certifications like ACLS and PALS, which is Advanced Cardiac Life Support, Pediatric Advanced Life Support. You can do those without experience. So you can find a training center. TNCC, I think you have to have you have to have a year of experience to do that. So they want you to have a year in the ER or in a trauma system before you go and take that training. And I think that's still required. All right, and that's just a quote that you can read, and I think it's self-explanatory. All right, I got a little bit of time for questions if anybody wants to ask anything. Or you can put it in the chat.
I've got a question.
Go ahead.
What was your most memorable or remarkable experience apart from maybe that 19-year-old with the gunshot wound?
Remarkable experience or memorable. So I can tell you this, that a lot of the experiences and remarkable things that occurred, I mean, there's a lot, but a lot of times it's just helping people. It's doing amazing things with amazing people and realizing that the person that we're treating, in another environment probably wouldn't have had such a positive outcome. That's just the nature of getting good at doing this. I can name 3 people that if I was ever hurt or one of my loved ones is hurt, that's who I want there, because I've seen them actually save people that probably shouldn't have been saved or couldn't have been saved anywhere else. So it's really those kind of things are remarkable. The work I did with kids is pretty remarkable. Helping kids who didn't have anybody else that came across the border and were just lost in a large city. I mean, those type of things were life altering. And I mean, it was that kind of work. Even helping my coworkers. I wasn't afraid to talk about my feelings and how these things affected me, because living in this world is not easy, and there's a high probability of burnout. There's a lot of people that can't make it, and it's not because they're not adequately fit for this. It's because you need actual tools to do this effectively, or you're going to get burned out. You need to take care of yourself. If you do not take care of yourself, you're going to end up a very bitter human being. And I don't want to see that happen to anybody. And so it's really important that we understand the gravity of this work, but that we also understand our place in it. And part of that is I have to take care of myself if I'm going to take care of other people. And so you have to be, it's a really strange revelation to come to that. Like, I got to be okay. If I'm not 100% mentally here, then I can make a mistake today. So it's a unique calling, but it's something that is very, very rewarding. All right, so I got a question here from Jesse. Do you think that mental health care for healthcare workers, especially first responders, should be mandatory or strongly encouraged and made more accessible? I would agree with all of that. I think that it should be accessible and encouraged amongst healthcare providers who are in these high stress environments. All of healthcare can be high stress. Taking care of ourselves should be an extension of the care that we give to others. And so I think making that connection and helping each other more than anything, fostering an environment where we are inclusive of others' feelings and reactions to these high stress things. We don't talk about these things very much, about and how they affect us. So it's definitely something that I speak from experience on, because I started this at such a young age. I started in trauma care when I was 20 years old, and I did not know how to process it. And I had the people that I saw in that world didn't know how to process it either. There was a lot of divorce. There was a lot of infidelity. There was a lot of people who engaged in a lot of high risk behavior because they were in this world. And so I really preach taking care of yourself and really talking about these experiences with each other. There's no better support system than those that work alongside you. Liz wants to know, do I have any tips for someone who is looking into a new grad position in critical care? Kind of the same thing. You can look, I mean, it's really looking for, there's AACN in that world. So you can join their professional organization as a student and foster any relationships that you have in that area. If you do, that's usually a good way to get started. Okay, is there anything else I can answer for anybody?
Patrick, I have a question.
Sure, Trevor, go ahead.
You said you started in the ED and now you're in the ICU. Like, what made you decide to leave the ED and go to the ICU?
I really wanted to learn critical care. You kind of scratch the surface of critical care in the ER environment, depending on what you actually do. But there was a lot of things that I needed to become more comfortable with. Having, like you've learned about vasopressors a little bit, having vasopressors started in the ED is a scary experience. I found this when I was like looking around today. I have a card literally that has the starting rates for different vasopressors. And I kept it with me because we rarely did that. So it was really, really hard for me to and also we didn't know how to titrate real well, and we didn't have training in that. That was really apparent during COVID when we were holding on to a lot of sick people in the ER because there wasn't enough space. ER nurses have a deficit in critical care, in managing ventilated patients. We intubate people and then they're gone. We don't manage a ventilator for a long time. We don't do suctioning and stuff like that. So I learned, it really helped to round out my knowledge base. And I recognized it very early on as kind of a hole in my ability to treat people. So, and also I wanted to be a flight nurse again, but then Kathy Foss, she plucked me out of my ICU and turned me into a teacher. So you can blame her, and I can blame her. So. Any other questions?
Patrick, I have a question.
Go ahead, Alice. Good to see you.
Good to see you too. I'm so glad that I was able to make it. So given the technologic and medical advances that you have seen since you first started, what would you recommend to that young Patrick to apply for the practicum? Like to get the I guess the most amount of nursing skills to prepare you for something like this, for example.
Alice, that's a great question. So if I had to talk to myself as I was in like the later my last semester of nursing school, I would probably encourage myself to either seek a practicum in a critical care environment so that I can because I've learned that in school, it would have been a really good progression to kind of apply it into a different world. Or possibly, and this would have been something that I think I would be interested in now, is that would have probably helped me in my future career, is learning OR, is learning, because that's such a huge part of the inpatient acute setting, that, and it's such a huge part of what I do now, that it would have been really cool to kind of exist in that world and see how it works, and be just to kind of get a better understanding of that. So those are probably the two things. Really good question, Alice. All right, there's another one here from Marissa. What recommendations do you have in order to be the most successful in the ED as a new grad? I'm worried about my skills, knowledge, matching up to the requirements of the ED. Would it be smarter to start on another unit to build on those things, or just dive into what we're passionate about? So that's dependent on a few things. ED culture is very important. So that kind of comes from the top down. So it's really interesting just to see how that affects like how you acclimate to a new environment. Make sure you have a supportive preceptor, a supportive educator. It is not impossible to start in that world. People do it all the time. So but that's important. And I think those are the questions that as a new grad during your interview that you ask. Hey, what kind of support do you offer your new grads? What is the training program? How do you train your preceptors? And so that you can get that impression of like, okay, this is a good place for me to start. Again, starting in a med surg environment just to get your skills down is not a horrible thing. It's actually probably very smart in this instance. Good question. Do you still teach those skills classes, and will we be able to sign up, register for those after graduation? So I do teach skills still. I work for a medical supply company, and I teach advanced practice skills to flight nurses. I do invite students occasionally. If you ever take one of my quizzes or something in my class, that's usually, but because of COVID, we've kind of stopped. I haven't done that in over a year. So I will always reach out, let y'all know when certain things like that might be going on. Yeah, but I do that occasionally, and I'm not always in charge over who comes to those things. But there are other opportunities. Those things that I talked about, that T&CC class will teach you a lot of skills. There's, just being in the ED environment will, you'll get skills training as well. So Ian, I saw your hand go up.
Thanks, Patrick. Thanks for taking time today. It's always fun to listen to stories of people who have a good history in the field that you're curious about. So my question is pretty quick. I've heard some ICUs like to hire new grads because they can train them up to the standard of the unit. Is that something you're familiar with or you've heard about?
I'm super familiar with that.
Okay.
My time as a clinical scholar was kind of a link in that chain. So just training new grad nurses in various areas and specialties. So you are 100% correct. So what a lot of units are looking for is a new grad who they can train to their level, rather than, they like experienced nurses as well, but there are various advantages to that. I mean, you have a set standard, and make sure that the new grad nurses can adhere to that. And there's a training program that's usually really defined. This is the things you need to know. This is what you need to learn to exist in this culture and to be a part of what we're doing. So it's very very clear. And then, so it's not a bad thing. One thing I will tell you all, and this is something that you won't hear from a lot of people. So a big reason why some hospitals like to hire new grads is because they are cheap. And so that they'll start you at a super low rate, and if you stay there for an extended period of time, you only get raises off of this super low rate. So I advocate for nurses being paid as much as we're worth, which is, in my mind, we're priceless. So we should get whatever's coming for us. We should be able to support a family. We should be able to pay for a house in our own city where we work. And that's just not my opinion. I think that's something that we've earned as a nursing profession. So I advocate for all of you to really advocate for each other and negotiate. Try to see if we can do something about this. I mean, there's a lot of places in the country that pay new grads very well. The place where I came from in Houston, Texas pays really, really well. And there are students that have gone there. So part of my advice sometimes is, keep your options open if you're not really like tied to what's going on here. But if you leave and make more money and then come back, don't let anybody pay you less, because you're not only advocating for yourself, you're advocating for everybody else that comes behind you. So I think that's something we need to talk about more as a nursing community, and that we need to be more upfront with and strong about, because I really want you all to have long, successful careers, and I want you to be able to exist and support yourself and whoever else you have and you love. So that's just my spiel on that, Ian.
All right. Thanks for sharing. Much appreciated.
No problem.
All right. Thank you, Professor Luna, so much for everything. This has been wonderful. It looks like you had one more question if you do have time. Otherwise, thank you. We will be sending you a thank you gift hopefully in the next few days. Really appreciate it.
All right. We can stop the recording and I'll answer the question.
Great. Thank you.